Welcome to our panel discussion. We've convened this panel to shed light on how harm reduction is incorporated in healthcare, and we assembled an esteemed panel of health providers to discuss their perceptions and current practices. Our aim today is to understand how health providers view the value and efficacy of harm reduction and how it might be incorporated into practice no matter what type of care provided. For some, harm reduction is at odds with medical dogma, the Hippocratic oath to do no harm, and to others it represents a new era of patient-centered and culturally competent care. For those unfamiliar with harm reduction, the general premise involves providing people with strategies to reduce the harm that can come from engaging in risky behaviors, not necessarily getting them to stop altogether, though. Another core tenet of harm reduction is that it meets people where they are. Because of harm reduction's flexibility, the concept can be applied to a wide range of behaviors, with smoking, alcohol use, sexual health, and drug use being a few of the more common examples. Of course, that description of harm reduction only scratches the surface. That's why we've invited this panel of health professionals and harm reduction experts to expand on the topic. With that, I'll hand it over to our panelists to briefly introduce themselves and describe their experience with harm reduction. We'll start with Ruth Ann.
Hello, everyone. Thank you for inviting me. Thank you, Chelsea and R Street Institute. My name is Ruth Ann Palumbo. I am a nursing professor at the University of North Carolina in Wilmington. I have certifications in education and addictions nursing, and my current research focus is integrating harm reduction into nursing practice.
Thank you. Amy?
Hey, thanks again to Chelsea and also again for R Street for putting on this panel about a super important topic. My name is Amy Ho. I am a ER doctor in Texas with an interest in harm reduction, particularly out of emergency practice, where we very robustly work on projects like naloxone, issuing with opioid prescriptions, buprenorphine or other opioid use disorder, medication-assisted therapy, counseling about smoking cessation versus harm reduction in tobacco and nicotine, and multiple other harm reduction strategies in other substance use.
And Jeffrey?
Hi, and again, thanks again to R Street and Chelsea for inviting me. I'm a pharmacy professor at the University of Rhode Island in Rhode Island, and I focus my work on pharmacists' role in harm reduction, sort of the other side of what Dr. Ho talked about, and that making sure the pharmacies stock buprenorphine to be dispensed, and making sure they have naloxone to be dispensed, and that we make policy change so that when people want these things, they have access to them, and that pharmacists are educated and willing and able to make sure that people have access to all these interventions.
And Randy?
Hello, everybody. I'm Randy Keir. I'm a community health worker with the nonprofit harm reduction agency HIPS. I'm a former commissioner on the Ryan White planning plan. I'm also a HIV hepatitis C specialist, a testing specialist. Thank you.
Thank you all again for being here. We're going to start off with kind of a broad question, and that's first, what is your general understanding of harm reduction by you and your colleagues in whatever field you're in? We're going to go in reverse order of what we did in introductions. So Randy, you want to take this one first?
I'm sorry. So most of my experience come from lived experiences. And harm reduction for me was a way to live my life healthier, better, and longer. And so, yeah, basically.
Great. Jeffrey?
Yeah, I think that what I try to make sure pharmacists know is that what they do every day is harm reduction, right? Providing education on medicines. There are adverse events with vaccines, and what are you going to do when a test comes, or when do you recommend testing? So all these services that we perform, both cognitively, providing education or actual services or medications, we're always trying to think about, what does this patient need? Is this the best medication? How do we educate our colleagues and the patients and their families to make sure that they don't have unintended consequences, whether it's a prescription drug or a substance that they've acquired in a different way.
Amy?
Yeah, I think Jeffrey said it really well. Harm reduction is kind of everything in medicine. Like everything we do in medicine is harm reduction, because every medication that you give has a benefit and it also has a harm, and we do our best to mitigate that. You even look at any common concept in public policy and public health, seatbelts are harm reduction for car accidents, masks and vaccines were harm reduction for COVID. So when you talk about harm reduction in the addiction spectrum, it's still operating within an extremely common paradigm of medicine, but it gets treated differently because of some of the stigma surrounding substance abuse. But I will say the general understanding of harm reduction because of that stigma is in general poor, because abstinence, despite most people moving away from abstinence only in sex education, abstinence when it comes to addiction is still very much the mainstream concept in healthcare.
That's so true. And Ruth Ann?
I think we still have a lot of work to do in nursing. I think higher education, advanced practice nurses are incorporating substance use disorders and harm reduction much better in their curriculums, but undergraduates, those bedside nurses, still a lot of really heavily congested curriculum, and substance use disorders and harm reduction kind of gets pushed to the wayside. So still a lot of work, a lot of education to be done there.
Thank you all. And what I love to hear from all of you is how broad harm reduction can be and how it can be applied to a lot of different ideas. So our next question is, why should health providers consider integrating harm reduction into their practices? We're going to start with Amy.
Yeah, so this is a topic near and dear to my heart because, one of my passions is certainly educating other clinicians about harm reduction, because life is imperfect. I know that probably more true than ever in the emergency department, because people don't end up there unless life was imperfect. And because of that, I think we can't wave a magic wand and have a perfect solution or have abstinence only. And so rather than allowing a lot of frustration for both the patient who's unable to meet you there at that moment, and also eliminating a lot of frustration for the clinician who feels like the patient's not meeting them, harm reduction allows you a solution that gets you incrementally better. And my belief as a health provider is certainly that you're on a journey with the patient, ultimately trying to come with perfection, whether that's perfection in health, perfection in function, perfection in their disease process. But I think we know that we probably won't achieve it, but should certainly celebrate the incremental improvements. So I think health providers being willing to accept that as a paradigm allows you better outcomes, and also allows you a lot more satisfaction on both the patient side and the clinician side.
Thank you. And Randy, why should health providers consider integrating harm reduction into their practices?
When I think about this question, I think about my own self and understanding that when I was introduced to harm reduction, trying to get off of drugs, all I could imagine trying to get off the drug is the abstinence part of it. I found that when a harm reduction plan is a part of the overall treatment plan, it takes a big burden off the individual, and he or she becomes more involved in their own health as I did. I wanted to know, what these big words were the doctor was using, what, RNA was, what CD4 was. I started attending more of my doctor's appointments. I started taking my medicines regularly. And the result of that is me being undetectable, able to help others reach these same goals. And so, yeah, I think that those are some of the things that will definitely make a difference. It does make a difference.
I think what I'm hearing you say is talk about incremental change too, and how harm reduction can help people really incrementally improve their health.
Right. You can go from homeless, from unemployable to employable. I've done it all. So, and as I said, you know, when I was introduced to addiction programs, it was always about just getting off of drugs. It was never a roadmap to doing that. So that's what harm reduction did. It gave me the roadmap. And not only that, the hope and the courage to be able to get it done. So
That's also a really important point, is how sensitive harm reduction is too. I'm going to go on to our next question. So that is, how can providing harm reduction services or counseling on harm reduction strategies improve patient or client health outcomes? And we're going to go in the same order that we did introductions. So we'll start with Ruth Ann.
So I believe, you know, from a research perspective, harm reduction reduces overdose deaths, it reduces infection rates. It is, you know, I mean, there's just so much that harm reduction can do. And from a nursing perspective, we are the largest healthcare profession with 4.2 million registered nurses. So we have a lot of hands-on with our patients directly. So I think incorporating harm reduction education into nursing programs and into the hospital where nurses can provide this education and give them to patients right there when, you know, it could be needed the most, during an overdose or during an acute exacerbation of substance use disorder or something of that nature. So I think that, you know, it's been proven to help patients into recovery.
Thank you. And Amy?
I think individualized care matters a lot. I think honestly, Randy's testimonial is probably one of the best on this panel about why, you know, forcing someone who wants help into one solution when it doesn't match them just breeds frustration and failure and possibly eliminates the desire to get better at all. So I think what this ultimately does, or what harm reduction ultimately does for patients, is it offers them a solution that's individualized to them. And again, improves, I think, outcomes, certainly for their journey in addiction, but also for their relationship with their clinician and their relationship with their addiction as well.
Thanks. Yes, we love to empower people with harm reduction. And Jeffrey?
Yeah, I mean, I echo my colleagues here. I think the thing that I like is it's about trust. I think that too many folks, especially those who use drugs or are you doing what society dictates as a stigmatizing thing, no matter what age you are, or life situation you're in, if you're doing something that's wrong or has been declared sometimes arbitrarily illegal, you're not going to talk to your doctor about it. You're not going to talk to your nurse about it. You're not going to talk to your pharmacist about it. And so I think it's that individualized care, but it's really about trust. And we have to, you know, part of this session is really to get people to think about integrating it into care, but really integrating we can't have people take control of their healthcare unless they trust their healthcare providers. Randy said, I went to my doctor's visits more. Well, if you don't trust your doctor, you're not going to go to your visits. If you don't trust the medicine because something happened that you didn't know about. So it's important to have that trust so that you've got, you know, trust in not only healthcare providers, but the system that too often still discriminates against folks merely for doing things that society has deemed illegal.
Absolutely. And Randy, do you have anything to add to that?
Yeah, that's just absolutely right. You know, I've been positive now for 36 years, just about. And my doctor left the organization or the provider services that I could afford. And when he left, I left with him. And I went to him because we had created this bond, this understanding I could share with him. He's the same doctor that helped me find a doctor to diagnose my stage 3 cancer just last year. And so I was able to talk to him about issues and become educated about things outside of my drug addiction with harm reduction. You know, and I saw the blood in my stool. I knew that was something I needed to immediately contact my doctor about. And though he wasn't a cancer doctor, he was able to give me the resources I needed to help me get through it. And here I've been treated through aggressive treatment, and I'm doing much better now. And that's just one more tool I can use when I'm out in the community, linking individuals to medical care.
Thank you for sharing that, Randy. I'm glad you're doing well too. On to our next question. What are some hesitations you've encountered from providers when it comes to integrating harm reduction into their practices? And what would you say to address these hesitations? Let's start with Jeffrey.
Well, we need policy change. I think we all say that. That's important. Providers also have a license, also are increasingly under threat to care for patients who need our care. And I think that's, we need to be advocates to change policy and say, look, here's this, Ruth Ann said, here's all this evidence if you do this thing. And, one example from pharmacy is, again, it's that trust thing, but it's the golden rule. When you refuse to see a patient who doesn't get vaccinated, well, you need to still talk to them about their healthcare. When you refuse a patient because they haven't stopped using some substance, well, we don't refuse it. And then we distinguish the substances differently if they're legal or illegal. Like, well, of course my patient smokes and I've talked to them about smoking cessation, but I need to care for their diabetes. It's always a different conversation than, well, my patient injects fentanyl and they have diabetes. I'm not going to take care of them at all because of this fear of that, or I'm not going to prescribe sterile syringes so that they don't transmit or acquire viruses if that's another diagnosis. And so I think it's, pharmacists don't like to sell syringes because they say that the patients say they see it in the parking lot. And I think it's really to imbue this community attitude to say, public health isn't about one person, it's about the community. So let's have a universal approach so that you're not feeling like I am targeting the person doing this person. You're just saying we offer PrEP to everyone, or we offer syringes to everyone, or we have syringe disposal here because everyone who uses syringes needs to get rid of them. And so it's sort of combining these things to say, how does the community benefit? Let's not focus on one particular group, and let's make sure that we're offering these services sort of to everyone universally.
Yes, and bringing up the sterile syringes is such a good point, because that's a point of policy change that can be addressed by either allowing pharmacists to provide syringes or just expanding the access that way. Ruth Ann, you want to ring in on this one?
Sure. I've had many conversations about hesitations, especially in research and trying to get things to change. It takes forever. But like, for example, we will provide naloxone to patients who have broken their hip and are provided opioid medications, but we will not provide naloxone to patients who have just overdosed and are being discharged. So there's a discrepancy there. And when we've talked about that, it comes back to that enabling piece, and enabling makes me a little nuts when I talk about it, but there's absolutely no research to support that anyone has to hit rock bottom to recover. In fact, it's the complete opposite. So what I say to people when they bring up things like that, isn't that enabling, or giving syringes or giving naloxone, doesn't it encourage? No, it absolutely does not. It does the exact opposite. If it were true that, you have to hit complete rock bottom, then our best research would be for patients who are homeless or patients who are prisoners. And those patients are, have the most difficult time recovering. So patients who are supported and who are given the tools that they need to be supported where they're at, and if that's harm reduction, syringes, naloxone, they're the most likely to recover.
That's a really solid point, is how harm reduction can really help people move along the spectrum, again, with that incremental change piece of things. So for our next question, I'm going to ask for others in your profession, what are some practical tips for implementing harm reduction in their day-to-day practices? And we're going to go with all of our panelists today, and we'll start with Ruth Ann again.
I think it's just important to provide people with the information, especially locally, local and national resources. So that's one thing that I try to do. When I talk to nurses, they have no idea what's available in our own town. They don't know what recovery service or harm reduction services are available. So making that widespread and known, and providing them that information so that they can in turn give that to other people.
Thanks. Amy, you want to go next?
Yeah, absolutely. I think when it comes to harm reduction, To be an effective counselor on how to implement harm reduction strategies for a patient, I actually think you need to understand how drugs are used. In the example of like IV drug abuse, you kind of need to understand that there's a needle so that you can recommend things like getting clean needles from pharmacies or exchange places. You can even recommend cleaning if needed, and people are reusing it, all as harm reduction strategies. You need to understand that, you know, there's a water that's usually used to dissolve a particular substance. There's also a filter. So again, these are discussions with patients about using a clean filter, or do they have cotton swabs? Do they know they can get sterile water from pharmacies? Do they know that if you need to sterilize water, you can boil it and then obviously allow it to cool? I think just understanding a lot of these tenets will show patients that you care. I've never had as many patients shocked as when I start asking them these sort of questions of where they procure their filters from, that sort of thing. And then B, I think it gives actionable options for patients to implement when they're not ready again to, say, do abstinence on their particular substance.
That's also such a good point to bring up, is that we oftentimes talk about syringe service programs, but we don't talk so much about the other pieces that can be provided to people who use drugs. And Jeffrey?
Yeah, I would build off of that to say, when I talk to pharmacists who do sell syringes, to say, you know, here's another easy thing you can do. You've given 100 vaccines today. What was the first thing you did? You wiped the skin off. You've got essentially free alcohol swabs here. They've not in short supply. Throw a couple swabs in the bag, you know, when you or ask your technicians to do it. Or from a patient-centeredness standpoint, we've done studies where we realize that when syringes are in the back of the store, somebody requests a 10-pack of syringes and they yell, do we have this 10-pack of syringes? And stigma settles on the person and the people around them, instead of, oh, we have this in the drawer and here you go. So we say, put syringes at the drive-through. What a great way to access that, again, for people who are privileged enough to have a vehicle or things like that. But it's sort of think about what's easy for you, what you're not yelling about, you know, this person's getting emergency contraception. Nobody wants to have that. So it's sort of, again, the golden rule, what's easy. And I think the other thing I like to educate is, okay, so you've decided that you're not going to sell syringes. What impact does that have by not doing it? So that sort of moral hazard related to naloxone, flip it on its head to go, what's the moral hazard of not doing something?
Yeah, there's been a lot of talk about moral hazard lately, so I like that flipping it on its head comment. Randy, do you have any practical tips?
So for me, I find that the bonding, because I'm a community health worker and 80% of my time is spent in high risk areas out in the community. The other piece to my is that I work for a harm reduction agency that offers wraparound services. So you can get your syringe exchange, you can get your housing, you can get a shower, you can get a meal, you can get a change of clothes, you can get mental health groups. And so the bond with me and securing that trust with the client allows me to, or allows the client to invite me in the areas where he needs, and meeting where he's at or she's at. It allows me to offer them the help, the services that we can help them with.
Right, the wraparound services are also a big part of a lot of harm reduction organizations, which help people so much, in addition to just providing, like I said before, just sterile syringes. So I'm going to move on to the next question, but I also wanted to invite our audience to use the Q&A function to submit any questions that they have for our panelists. We will get to those if we have a little bit of time at the end of the panel. Our next question is, on a more systemic level, what do you think needs to change for harm reduction to be more widely embraced by the health provider community? And let's start with Amy.
Yeah, that's a great question. I think there's a couple big things that the health provider community needs to understand. One is that addiction is a disease. Like, while I think people do know it, I don't think they always believe it. But again, when we talk about classic medical treatment, i.e., say diabetes, no one has any second thoughts about prescribing metformin or insulin to mitigate the harms of diabetes when perhaps diet, exercise, and lifestyle are not possible or not successful. But we don't treat addiction medicine the same way, because ultimately I think people have subset it as not really a disease the way, say, diabetes is. I think the second thing that we really need health providers to accept is that abstinence only generally fails. And again, we live in a world where we would love for perfection to exist. But I think once you accept it doesn't, it makes harm reduction actually the only strategy that you can implement. And then lastly, I think there is some policy changes that need to be there. Things in medicine are incentivized ultimately by reimbursement, which is set by the government. There is very little reimbursement for the counseling and the education that someone needs to be appropriate and successful at helping patients with harm reduction. And I think having government changes for that, whether it means more education, more CME, more funding reimbursement, would all encourage the field to move that way.
Thank you. And those policy recommendations are definitely well taken. And Randy, what do you see as some of the systemic level changes that need to be moved towards?
I think the biggest one for me is the myth that harm reduction is enabling. I think that when you have a harm reduction option, you become more involved in getting better, whether it's behavior or whatever.
Thank you. Yes. And there's a question about a recent paper that just came out in the chat, which I think since we talked about moral hazard, I'm going to weave this in really quick. So the question is, have any of you reviewed the results of the new paper by Packham that shows that although needle exchange programs reduce the spread of disease, they also increase the rate of opioid overdoses? Not to put you guys on the spot, I know there's always a ton of literature that comes out, and so it's hard to keep up with anything, but has anyone seen that paper recently? If not,
I have. Or Ruthann, you want to take it?
Go ahead, Jeffrey. Or which one?
I have not. Jeffrey, go ahead and speak on it. I want to hear what you heard.
Yeah, this is probably a whole other hour talk from my colleagues in this. I think the sort of overarching idea is that economists are not public health practitioners nor clinicians. And it's great to team up with economists. I've done that on some papers, and that from a health economic standpoint, I think that's great. But economists see the world very differently and not in a public health way. And so you always have to be cautious. This is like the moral hazard naloxone paper that came out from two economists a few years ago. Really false kinds of things. And so this paper looked at syringe service programs, but it only looked at those that they could find. And half of syringe service programs, this is a big important policy piece, are unknown. They're not listed because they can't be, right? I mean, we have overdose response centers and supervised injection facilities in the US. They're underground, they're not on the list. So you already have a lack of data baseline. And then it's this idea that people are using more drugs when they go to SSPs because they're meeting more people. I mean, that's just not true. And I think that I encouraged by my colleagues who are more expert than me in this to say, visit an SSP, talk to Randy, talk to anyone who's ever taken care of anyone who ever wanted to help themselves. They're the people going to SSPs. They're the people going to pharmacies and buying syringes, as stigmatizing and as difficult that sometimes is, unfortunately, in many places. They're the people who, when Amy asked them about their drug use, they're still saying no, because they're still going to the underground SSP and they're not going to reveal that. So I think it's important to analyze this. It's a stain on harm reduction, this paper. And I guess I would just add anyone to have caution about where's the data coming from, what is the expertise, were there peer reviewers who have expertise in harm reduction, public health, who've been to SSPs, work in that setting, and they really have it. And so we really have to be cautious about ecological fallacy and, where SSPs, they're in places where there's high overdose rates because maybe they're needed there. So again, there's a sort of before and after, and they do fantastic statistics that I can't begin to explain, but it really starts in a poor place in terms of the analysis.
I'd like to add something, Chelsea, very briefly, if I can.
Of course.
About the research aspect. Just if that research was done in the United States alone, I would be cautious of it because we're so new to the game with harm reduction and widespread research. If you're looking for very valid research, I would look at Europe, Canada, Australia, who have been implementing harm reduction services and keeping track of and providing that that research for many, many years, and have had like safe consumption sites and no overdoses in many years. So, and also the increase in fentanyl in our area. There's just so many factors that go into a piece like that. You have to be very cautious.
Thank you, guys. Yeah, those were all really good points. And just we posted a Twitter thread today about that paper. So if people are looking for something that they can share, that is on Twitter, on Our Street's Twitter. Just to shameless plug. And let's see. So back to our other questions. What are some structural or policy barriers that you believe inhibit harm reduction health provision? So things like insurance billing or state legislation. And we'll start with Ruth Ann.
So there's, oh gosh, this is a rabbit hole of a question, truly, Chelsea, because there's so many different things that you can talk about when it comes to policy and funding. I will say that a lot of funding, whether it be private insurance, whether it be Medicare, Medicaid, they will pay for harm reduction services, a pay for fee type of thing. But it's all dependent on the type of services that you get. It's all dependent, is it inpatient or outpatient? A lot of these things don't pay for outpatient services, which a lot of our patients with SUD need long-term care, not just inpatient types of things. So there's a lot of different things. Federal funding, will provide some, funds for harm reduction, but they will not allow for the supplies, the syringes and things like that. There are a ton of grant funds that are available. I know that SAMHSA had 10 million come out in 21, and I think 30 million come out in grants in 22 specifically for harm reduction. I know they just passed a policy, Biden did, for 30 million to go towards harm reduction. And then, the opioid settlement has been distributed amongst the states. So there's a ton of stuff out there, but it's very complicated, a very complicated system. And there's all these little caveats. Some grants allow you to get supplies, some don't, some funds do, some insurance, companies will cover it, some won't. So it's just a battery, just a lot of different things to take into consideration.
It certainly is a rabbit hole. Jeffrey, do you have anything to add to that?
I mean, the biggest policy barrier is the belief that law enforcement works, and it doesn't. And, the drug war has failed. We need reform. The Office of National Drug Control Policy has said reforms like, again, it's important for the listeners to understand, treatment is prevention. If you're on methadone, if you're on medication, if you're on Suboxone, or if you're on naltrexone for opioid use disorder or other medications for alcohol use disorder, we embrace nicotine replacement therapy. Don't really like that term, but that's what it is. We need medications for addiction treatment or for OUD, and we need greater access to that. So we need policy change to make sure that that is as available as possible. We need when, for example, methadone and Suboxone to treat opioid use disorder, again, treatment as prevention here, people don't have overdoses when they're on buprenorphine. They are rebuilding their lives and solving these other complex intersectional issues in their lives when you're not dying, when your friends aren't dying of opioid overdose or your partners. But the problem is that we need as many providers as possible with the greatest access possible. Now, there's some federal legislation perhaps being integrated into an omnibus bill that I'm sure Our Street knows about, the MAT Act and the MATE Act, to try to release some of these documentation issues. So there's all those sort of technical things. But I think the important thing is that as clinicians, we know you only get paid, you only do the things you get paid for, or your employer only has you do the things that you get paid for. So from a pharmacy standpoint, if a pharmacist is going to refer people to local services for, like Randy said, all those other things, if they're going to test you for HIV and Hep C, all those things can happen in pharmacies, but only if you get paid. So that sort of low barrier access isn't going to happen. And if a grant is paying a drug user health program to provide those services, and the grant goes away, that they go away. So we need sustainable, adequately reimbursed solutions without policies that inhibit unnecessarily these kinds of things. One example is drug paraphernalia. You mentioned this earlier, Chelsea. We have to eliminate drug paraphernalia laws. There was a paper in the New England Journal of Medicine saying, my colleague Corey Davis and others saying, why do these exist? They're proven wrong. But as we know, once a policy is passed, it's really hard to reverse it. And when there's such a push and a belief, a societal belief, that if we arrest all the drug dealers, the drugs will go away. If we shut the border down, there won't be fentanyl in the US. These are great talking points. They're not true. And so we kind of have an infodemic of these types of things. And states are actually aggressively pursuing those kinds of laws on the backs of parents and others who have lost people and who really believe that this is the way to do it. And so we really have to have sort of a compassion push to say, look, everybody, these laws aren't working. We need a harm reduction approach, not a law enforcement approach. We also still need to partner with law enforcement in ways and educate them to keep going.
That's such a solid point about the drug war and law enforcement's role as well. I'm going to invite Amy and Randy too, to if they have anything to add to this question about policy and structural barriers.
So I just wanted to mention that the organization I work for did a pilot program, an anchor pilot program, because insurance companies refused to pay for treatment for individuals who had hepatitis C as long as they were still using. Our program proved that they could still be treated although they were using. And this changed the insurance company's policy. So again, a lot of policies out there, including insurance companies, really need a lot more work.
Yeah, I think there's some prescriber-specific policy benefits as well that we could possibly implement. For example, to prescribe buprenorphine or methadone, you actually have to have an X waiver, which is historically like additional classroom time, et cetera. It's been largely liberalized actually because of COVID. But that was a policy that I think was against harm reduction in a way, because it made it seem like buprenorphine, which is highly effective at helping in opioid use disorder, is, worse than prescribing, Norco or Vicodin or something like that. I think Jeffrey's already kind of mentioned, things in healthcare are driven by money ultimately. So reimbursement, funding, et cetera. I also ditto his comments there, but I think decreasing some of the barriers on just allowing people to do appropriate harm reduction, i.e. eliminating the X waiver requirement for methadone and buprenorphine, would also be highly helpful.
Yeah, thank you all of you. Those were great answers for how we can come up with some policy recommendations for expanding harm reduction. So I have one more question, and then I see that we have some more audience questions. So I'm going to go through the last question on my list, and then we'll get to the audience questions. The last question is, do you think current education sufficiently prepares new practitioners to engage in harm reduction? What is working well, and what are some areas for improvement? We're going to go through all of our panelists on this one. So let's start with Amy.
So I think this is a really good question. The brief answer that I have is no. So I think from a pure education standpoint, it's not that education needs to happen as early as medical school or nursing school. I think it needs to happen even before that. You look even to K through 12 with sex education still being controversial for abstinence only versus, discussing safe sex practices. Like, these are not helpful for people as they age in their education, especially if they go into healthcare, in terms of understanding harm reduction. I think from a clinician standpoint, meeting patients who identify as addicts is extremely, extremely helpful in doing that early, because it helps to break down a lot of the stigma we have around the disease and also around what this patient population looks like. And then lastly, I think having more continuing education for harm reduction would be helpful as well, because medicine is very specialized. Like the cardiologist sees hearts, the nephrologist sees kidneys, but addiction touches all practitioners. And it's not just addiction medicine or psychiatry. Surgeons have to understand this because they prescribe pain medicine. Emergency medicine certainly has to understand this, as well as primary care doctors. But if you treat the patient as a holistic person rather than carved up into organ systems, addiction is pervasive through all of it. So CME will support that for people later in their career.
Muted. Continuing education is a really good point. Randy, do you want to ring in next?
So yes, I think so. I think that the funding is there. The conversation is greater than it's been in some time. And it's not just for the client, but it's for the medical professionals to talk to each other and to use these tools to help the client.
Thank you. And Jeffrey?
Yeah, I echo Amy's thoughts on, we need to do this early. Everybody, I'm guessing that people on this panel will say not be fans of DARE, or just say no. These things don't work. It's important to, and I'm a father, I have 2 young kids, and it's sort of, hey, here's the world. This is where it is. And this is another increasingly contentious area in many parts of the country where, parents want schools to only teach a certain thing and not expose them to new things. This is something we need to watch in our field so that people get exposure to these things. If we take drinking, I just read a paper that only the US and Russia really has a culture around consuming lots of alcohol in very short periods of time. So doing shots and things like that. Whereas in Europe, or where alcohol is it's just part of the culture. And yes, there are people who have alcohol use disorder, obviously, but at greatly lower rates, greatly lower community rates. Of course, national healthcare helps with those things. They have their problems with education. I think that's important. And I think my final point is this panel is what our college students, high school students need to see. They need to see there's a wide variety of clinicians. We're all unified in this. We push at my school interdisciplinary care. We have a day devoted to opioid use disorder treatment. And I always tell my students that as a professor, that if you can treat addiction, you can do anything, because it does affect not only all the organ systems, right, depending on the drug and things like that, it affects all this person's life. You've got to address where this person is in society. You have to address racism. You have to address unstable housing, unemployment. This is the way to say, look at all these societal problems that you're not going to fix as a clinician, but you have to understand that. So when you see that in patients who have lack of access to primary care or those other things, and really, again, it's what we started out by saying, it's meeting the person where they're at, no matter where they are, to say, what are you interested in? In pharmacy, we call this motivational interviewing. Nobody likes to go to the doctor and be told, here's where it is. You don't go into the grocery store and they're like, you are getting carrots, but I don't like carrots. Well, no, people want choice, and that's what builds trust. That's what we want. And so again, back to that golden rule. So again, from teaching, I think it's important that I always start my talks by saying, what do you want? And what happens when you don't get what you want, right? You're also all very privileged, likely. And so you have been getting what you want. So we really need to expose folks to a diverse array of opinions and experiences and say, there's a lot out there and we really need to build from this.
Thank you. And Ruth Ann, you want to close us out on this one?
Sure. I'll just, again, what Amy said, no, education does not sufficiently prepare our practitioners, especially from a nursing standpoint. Like I said, Those bedside nurses, the registered nurses that are going out and treating the patients at the bedside, it's being taught under the umbrella of mental health. And so it's a very tiny little piece, and harm reduction, if it's talked about at all, is a very insignificant piece of that in that curriculum. So we could be doing a much better job with that. Practitioners should be getting the X waiver. We just got a grant for our psych mental health nurses to have that upon graduation, but that wasn't something that they automatically did. It was something they were going to have to pay for on their own. So I do think that we need to incorporate that, especially in the nurse practitioner programs. So no, it currently isn't there. We're making some headway, but there's a lot of room for improvement.
Thank you all. Some audience questions, and so kind of we'll figure out who answers what, but the first one I'm going to ask is anyone aware of any US health system that's approaching nicotine use like the UK and embracing harm reduction and focusing on eliminating smoke, not nicotine? Does anyone have anything to add to that?
I'll comment on that one. The brief answer is no, but it shouldn't be that way. And I think it's worth discussing. I think on this panel, we talked a lot about opioids, IV drugs, et cetera, but we actually neglected to discuss nicotine. And what's really striking to me is that if you go to, especially inpatient rehab centers, often people are there for their drug of choice, cocaine, alcohol, IV drugs, et cetera, and they'll actually shift to smoking when they are working their program for their cocaine or opioids. And smoking is something that we haven't talked about a whole lot, probably because we did decades ago. But there's the exact same analogy there for nicotine and tobacco, that combustible tobacco causes cancer. Nicotine, even in long-term use, can actually be okay, similar to how methadone or buprenorphine in long-term use can be okay, but IV heroin is riddled with medical impact. So punchline, no, not aware of any US health systems, but agree that the US is quite behind our European counterparts on this issue.
US is behind European counterparts on a lot of harm reduction issues. Does anyone else have anything to kick in about tobacco harm reduction at all?
I mean, I think this is like, I'm really moved by Randy saying all of these services that his program provides, and this, I've worked in a methadone clinic and treated Hep C patients, and realizing, been to Hep C conferences where it's like, people want to get treated, they can cure themselves of Hep C even while they're using drugs. It's this idea of agency. And so I think agency implies choice, is that instead of saying, here's nicotine replacement, here are these two pharmacologic substances, why don't we say, can you switch to vaping? I mean, maybe it works for some people. I would never promote abstinence as a primary option, but I want to give it as a menu of options because some people, it works for them. Not all people. It's not an evidence-based thing, but it's something that works for some people. I think that the UK is doing well in saying, look, let's protect the community. Let's remove, when you're around a campfire, you don't inhale smoke. So inhaling smoke is bad. But in a controversy, in a counter example is, we also tend to see people who are injecting opioids switching to smoking opioids or stimulants. And we say, maybe that's a safer use too, as long as you have the tools to do safer smoking, for example. So there's a lot of ways here, but it really comes down to, what does the patient want? What does the person want? Give them those tools, pay for those tools, and we'll get them to where they need to go.
Thank you. Yeah, I think that is something that we didn't get to touch on as much in this panel, is some of the harm reduction methods for other substances besides opioids. But it's nice that we got to have a little bit of a discussion about it now. Our next question is, as a licensed clinician, I have several clients who often engage in risky behaviors despite harm reduction abstinence protocols in place. Recognizing that stranger things have happened, how can I continue to encourage my fellow clinicians to focus on reduction rather than abstinence in a field dominated by black and white diagnostic thought? Does anyone have anything to add to or to say about black and white diagnostic thought?
I think I'll chime in on this one, not a, counselor or a social worker, but I think also, clinician that encounters this a lot. I have found honestly that the black and white thought is certainly pervasive, but not immovable. So I feel like a lot of it is education. A lot of it is sharing your patient stories. A lot of it is sharing your approach to these patients, because as a respected colleague, as someone they know, I actually think that's a great way to sway them and honestly just educate. I personally think clinicians are less stuck in the black and white and are more willing to adopt different paradigms.
I'll jump in here. I think that I agree with all those things. I think what's hard about black and white diagnostic thought, I'm going to just bring up cost. We're not paid to solve all the issues of why a person's using drugs. So we can talk about harm reduction, we can provide these systems, we can do policy change. But if people aren't housed, that is something that not many people have experienced in the medical field, and so really can't even wrap their mind. I can't wrap my mind around this idea of, would I use drugs to cope with being unhoused or unemployed or separated from my family, whose society told to let me reach that rock bottom that Ruth Ann talked about. Sometimes you can do harm reduction and it's not going to stick. Just like you're going to say, I'm going to get on the treadmill every morning. No, I'm not. And so I think that there are parallels to sort of give people time and understand that some of these problems are intractable, and you just have to stay persistent and maintain that trust and the social justice aspect of these things.
Thank you, guys. Let's see, we have one more question, and I'm not sure if you guys are going to be aware of this one, but someone was reading about a lawsuit against a harm reduction group called MAPS, which is psychedelics. Does anyone have any knowledge of it? If not, that's totally okay as well. All right, I will just say I've heard of a couple of these going on. I don't know a lot about what's going on with it, but I have heard of a couple of lawsuits, just to kind of answer that person's question. I just wanted to ask a little bit, since we were talking about housing, and since Randy's organization does a lot of wraparound services, I just wanted to inquire a little bit about what the Housing First model is, and if you could kind of explain that maybe.
So honestly, I just know that we offer housing assistance, and the Housing First model I'm not familiar with.
Okay, yeah, so basically just that housing, we should house people before giving them other.
I can certainly say that. Okay, I see what the point you're making.
Yeah.
Yes, he's absolutely right. Housing is the number. If you don't have a place to sleep, I've been homeless, so I've slept my head, trash can, all that. But until I got housing, whether it was a treatment program, Oxford House, couch and surf to surf, it was better than sleeping outside, but it gave me the rest I needed to function the next day. And when I was able to get that bit of rest, everything else sort of like fell in place if I just could maintain that. Yeah, so that housing is number one. That's absolutely right.
Thank you. And we have just a few more minutes left. I just want to invite any of our panelists, if I didn't ask any questions that you would like to, if there's anything that you'd like to say that I didn't get to in our questions, feel free to ring in now. Just go off mute and you can say anything if you'd like, not to put you on the spot.
I'd like to just say that it's so, and this kind of goes back to the licensed clinician question, is whenever you're looking into harm reduction practices, to utilize the research, utilize the evidence-based practices. There's so many opinions when it comes to harm reduction, and so much stigma wrapped around opinions. And I'm incredibly opinionated, and every time I've tried to have a conversation utilizing my opinions, it gets heated. But if you stick to the evidence, and there is so much evidence out there that harm reduction works. It works. It keeps people alive. You can't help people that are no longer with us, you know, in the midst of an opioid epidemic, inside a mental health crisis, inside, you know, a pandemic, inside a fentanyl epidemic. We have so many things going on right now. We need to keep people alive. We need to meet them where they're at. We need to give them clothes if they need clothes, homes if they need homes, you know, medication assisted therapy, wherever they are, we need to help them and utilize the research that's out there, the good research that's out there. And again, you know, Australia, England, Canada, these guys are miles ahead of us in harm reduction. And that's what you should be looking at when you want to see the right statistics on what works.
Definitely following the evidence is so vital, and there's a lot of it, and a lot of our and several of our panelists here are contributing to that too. Well, since I don't see any more audience questions, I am going to wrap it up and give everyone back 4 minutes of their day. I want to thank our panelists again for joining us. This was really excellent, and I feel like we learned a lot during it. And everyone on the call, thank you for joining us for our panel. We always love having you. And this will be posted on Our Street's YouTube in the next couple of days. So if you want to share or come back and look at anything, you can see it there. Thank you, everybody, again.
Thank you. Everybody have a great day.
Thank you.
Bye-bye.